Welcome to Coffee with Cornelius. For a month or so, many of us have been living under strict lockdowns due to the novel coronavirus. We cannot go to school, we cannot attend church or synagogue, or we cannot get a haircut. All manner of get-togethers are banned, and much of this has been done under the guidance of scientific experts, epidemiologists, public health physicians, and so on. These experts base their advice on mathematical models. Our guest today questions the wisdom of relying too much on such models, especially the much publicized Imperial College London ICL model of Neil Ferguson and his group. I am joined today by Phil Magness, a senior research fellow at the American Institute for Economic Research. He received his bachelor's in political science from the University of St. Thomas in Texas and his master's and PhD in public policy from George Mason University. Phil's research includes the history of economic thought, economic history, slavery, and inequality and taxation. He is the author of several books, including The 1916 Project, a critique, and Cracks in the Ivory Tower. Phil, thank you for joining us.
Oh, thanks for having me.
So this is, of course, a weak criticism, and I tell my students that this is a logical fallacy. We cover this in my Econ 1P91 first-year economics course. Appeal to experts. However, let's get it out of the way, right? Just so that we can get it out of the way. You are not an expert in public health, medicine, or epidemiology, or any of those related fields, are you?
No, and I'll put it out on the table. I primarily work in economic history and study economic data, mostly pertaining to taxation and then some higher ed. But this has been an interesting opportunity as one of my first forays into the healthcare field.
So you're not an expert in any of these fields, but you're very critical of these fields. What
Right.
qualifies you to make judgments about epidemiological models and non-pharmaceutical interventions like lockdowns or quarantines?
Yeah, I'd basically make the same criticism that I would of most fields in the social sciences and quite a few in the physical sciences. And that is that statistical forecasting, statistical analysis often tends toward overstating the confidence of its claims, overstating the validity of its claims relative to the amount of information that we have. So I approach this as a social scientist that works in quite a bit of other statistical areas, and would just point out that, you know, statistical norms don't recognize strict academic discipline boundaries. Methodologies are common across the field. The second point I'd raise on this, I said, and I come at this as a scholar that encourages interdisciplinary work, but many epidemiologists are well versed in virology and transmission of diseases and healthcare, but have very little training in economics or public policy, even though their models actually pertain to both. It's not just diagnosing the disease and projecting its trajectory, it's also offering policy advice on what to do in response to those diseases and what the effects of those policies are supposedly going to be. And I'd argue, you know, that's something that economists, political scientists, people that work in the social sciences more generally have a lot to bring to the table to epidemiology that's often missing right now.
And also, you know, just this appeal to experts, this idea that just because somebody's an expert, they're right, doesn't make any logical sense, right? If we went back 1,000 years, all of the astronomers would be telling us that the sun revolves around the earth, and that would, of course, be wrong.
Yeah, and in particular, you even find in epidemiology, there's not a single expert consensus. There's quite a bit of back and forth debate. There are conservative models, there are models that trend in a more alarmist direction, and then there's everything in between. So epidemiologists themselves are having this discussion internally. Other scholars in related fields that have insights to bring to that. It's not just beating up on epidemiology, it's rather, let's tap our common knowledge, tap our various skill sets, to try and figure out this problem.
So in your personal estimation, how should governments respond to COVID-19?
Yeah, so and I preface this again as someone who is more oriented to the policy side than the diagnosis of the virus, but my own take on it is that the steps that most governments have implemented right now have failed pretty badly. One that I'd point out as a heavy point of criticism is the way that governments have handled nursing homes. And we see this over and over again that nursing homes were known early on to be an acute point of vulnerability where this virus takes hold. It basically gets into the door of a nursing home, and you have large amounts of a very vulnerable population demographically that's suddenly exposed to it in closed confined quarters. And that's why you find that in some states and some countries, as high as 50 or 60% of the deaths are being recorded from nursing homes alone. So it's very clear that this is an acute problem built around some very vulnerable locales, and yet that seems to be de-emphasized relative to other things in some of the policy response. We've done this more generic, one-size-fits-all, let's lock down all of society, have social distancing norms in place, whether you're in the middle of New York City or rural Iowa. Kind of this approach that says all of society must follow a single set of rules and a single strategy to mitigate it, that has pushed some of the nursing home attentiveness into the background. In the worst instances of this, we're starting to see stories out of New York and Pennsylvania that they even adopted policies that, to deal with projected hospital overflow, they remitted nursing home patients that had been diagnosed with COVID back to care of their nursing homes once they had been perceived to move beyond the point of vulnerability. And that's like taking this highly contagious disease and sticking it right in the middle of a locked down facility where most of the other residents of that facility are the exact demographic that seems to be most afflicted by it. So I'd say as my first response to COVID, if we had an alternative policy that addressed the nursing home problem more acutely, that may be a better way of going on about it. Then I'd ask, what can government do? What does government have certain functionalities that may not be suited to other actors in society? Well, we know that they can provide large-scale information, being data aggregators. Unfortunately, the CDC and WHO have proven pretty poor to
Very
that
bad.
task so
Very
far.
bad, yeah.
Yeah, we know that governments could be both a funder of last resort and a supplier of PPE equipment, of hospital equipment. They could even direct resources to building hospital capacity in areas that were targeted. So, some of the pop-up field hospitals that were set up in New York City would be an example of that. I think some of these policies had quite a bit of promise. They also tended to be fairly poorly executed. And then my final observation, this is where my own preferences tend to steer toward, is something that's more akin to a Sweden-style response, or we've seen a few of the states in the rural parts of the United States have adopted this a similar response. I think South Dakota is one that keeps coming up as an example, and that is not going into full lockdown, but canceling large events, maybe closing down concert venues, sports stadiums, movie theaters, things like that, but also encouraging business as usual to go on with certain precautions put into place. Wash your hands, wear gloves where necessary, wear masks where necessary, pay greater attention to hygiene and greater attention to the circumstance on the ground, rather than, again, this one-size-fits-all where we impose a lockdown and an arbitrary line between essential versus non-essential that no one seems to really have a clear functional definition of state to state.
Okay, so you've praised Sweden's approach to the pandemic,
You know,
which involves no strict lockdown procedures and otherwise free movement and moderate measures. People are traveling to the mall in Sweden, they're going to restaurants, they're eating there, they're going to school. Life is more or less normal. However, Sweden appears to be free riding off other countries who have imposed strict lockdown and quarantine protocols. And what I mean by that is if every country around you implements strict lockdown procedures, it is quite possible that if you don't do it, you're just free riding off those other countries' success, right? Secondly, Sweden's death toll has been significant compared to other Scandinavian countries. Is Sweden really a model to follow?
Right. So I guess we take that in different steps. On the free rider question, it's something to pay attention and be concerned about. But you could also make that argument in the inverse, that Sweden is acquiring a greater level of herd immunity, and its neighbors that have locked down are not. So 3 months, 4 months from now, Sweden may be in a much better case. Whereas you start seeing relapses in societies that went too far in the lockdown direction. I would
But
point out that
I do have to ask, though, is herd immunity established? And what I mean by that is, For example, influenza viruses keep reappearing year after year, and nobody
Sure.
really develops a herd immunity to those. Could this novel coronavirus also be something that eludes herd immunity entirely? And if so, isn't it better to be safe than sorry?
Well, I think there's quite a bit of uncertainty because it is a novel virus. It's something we
Hmm.
have never dealt with before, so you never quite know exactly how that's going to play out. What I have seen so far, some of the tests that are coming out of South Korea have established pretty clearly that people do retain antibodies from it, that there are not reinfections. You know, a couple of weeks ago, we were hearing news stories about people reemerging and showing that they were testing positive for coronavirus, and what it ends up being, it's actually false positives from the antibodies of when they had it a month and a half or 2 months ago. So I think that just based on the evidence that we have right now, it does seem to be um, pointing in the direction that herd immunity is something that we can expect to emerge from this. Now, is it the perfect solution? No. Are there uncertainties? Absolutely. But just with that caveat in mind, it does seem like that there's enough reason for Sweden to have a basis in staking this out as a policy.
What about the death toll in
Yeah.
Sweden?
Yeah, so which is interesting because Sweden does lag behind the other Scandinavian countries, and you're really only talking three other countries if we're excluding Iceland from that, which is just a separate story, separate geography. But compared to Norway, Denmark, and Finland are the three that are often tossed in there. Sweden does have the highest death toll. Sweden also has a much higher population. It's about twice as populous as any of its Scandinavian neighbors. But what I'd point out is we need to actually broaden our point of comparison here. Let's look at how this virus is playing out, not just in these three very small neighbor states, but in Northern and Western Europe in general. And what we find very quickly is Sweden actually has a much lower death toll per capita than almost any other major power or economy in that region. So I looked up the stats this morning. I think Sweden had 244 deaths per million. Compare that to France. France had 369. The Netherlands has 275. UK is 384 per million. Italy's 458. Spain's 525. In Belgium, which is probably the closest in population size to Sweden out of all this group, has an astounding 647 deaths per million. So you're starting to get to the territory of almost three times the rate. And all these other societies, all these other countries are on pretty severe lockdown policies where Sweden is not. So the question I'd pose in just assessing this, remember, Sweden's strategy does set out to build herd immunity very early on. And they did this consciously, recognizing that, yes, this is probably going to put us in a worse state of infection relative to someone in the immediate term on a heavy lockdown. Although we're seeing that's actually not playing out in places like the UK, Belgium, Spain, France. But for Sweden's strategy to work, the point I make is it doesn't have to do better than its neighbors. It doesn't have to do better than all of Western Europe to vindicate its approach. It just needs to be not substantially worse. And I think they're very clearly meeting that. And not only are they not substantially worse compared to their neighbors, they're actually doing better than other societies that are, in fact, on
So I
lockdown.
want to press this point a little bit further, and I don't want to press it
Sure.
too far, but I do think that this is a productive sidetrack, and I do want to explore this because you're bringing up a few good points. But I don't see the use of comparing Sweden to a country like the UK or Spain. I think it makes sense to compare apples to apples and
Sure.
oranges to
Sure.
oranges. And Sweden, quite frankly, is most similar to Denmark, Finland, and Norway in that regard. So wouldn't it make sense more to compare it to the other Scandinavian countries? And when you do, it does have a higher death toll. Now, I don't know how that death toll is compared to the population,
Right. Right.
and it I think it still is higher when you do it on a per capita basis. But doesn't it make sense to just compare like to like as opposed to comparing Sweden to Spain, which is a completely
Sure. Sure.
different environment?
Well, I see. Even if to go take it even a step further,
Yeah,
if you want to compare like to like, you need to start looking at urban area to urban area. You know, Sweden's a very large country where
sure.
something like 85% of its population is in basically three cities. And one of the cities, Stockholm, far and away outweighs the others.
Hmm.
And Stockholm is acutely hit again, and the concentration of that in Stockholm, just like almost everywhere else, is in nursing homes. How
Right.
does Stockholm compare to another major European capital that's a relatively dense urban area? It doesn't seem that Sweden is performing terribly worse than than another similar situated type of a city. Rather, what we find is that there are much more complex effects that you see that are acute to being in urban areas, or maybe acute to outbreaks that took place in nursing homes. And I think you're seeing quite a few of these European states are just like the United States, admitting that their nursing home policies missed the mark early on, admitting that this is something that was a greater problem than they anticipated. And I think we can absolutely include Sweden in that boat. One other caveat, if you want to compare Sweden and Denmark, they're right across basically a very narrow body of water from each other. The city that's immediately opposite of Denmark is Malmo, which has
Hmm.
not seen an acute outbreak. It's less densely populated than Stockholm, but compared to what's going on just across the channel on the other side in Denmark, there's not really an outlier that's emerging there. If you get close geographies of quite similar types of populations, not only that, populations that are used to basically driving between the two countries on a regular basis.
All right, so let's talk about the science. Okay, many of the projections for COVID-19, including death tolls and number of infected, which we have been talking about so far, they are forecast using epidemiological models, that is,
Right.
mathematical models like SIR models, SEIR models, etc. What are some of the problems with these models?
Yeah. I can start more generally, and then we can go into some of the particulars.
Yeah, sure.
So I refer readers. The NBER put out this great little synopsis type of a lit review of all the epidemiology models that have been applied to COVID, and they compared, I think, 4 or 5 of the major models that are in the discussion, and they made two very astute statistical observations that seem to be common patterns afflicting these major epidemiology models. So the first one is they say they note that insufficient attention is paid to behavioral responses to knowledge of the pandemic, and then also knowledge of the policy responses to the pandemic. So it's kind of like an epidemiological Lucas critique type of an observation. There
Sorry,
are
for those of us who don't know, what is the Lucas critique?
Yeah, so it's basically, I guess if you were to condense it into, language for the standard person, the gist of the idea is that individuals modify their behavior in response to knowledge that is
Right.
presented before them. So the classic economic explanation, this is always normally associated with monetary policy. So the Federal Reserve takes an action, people are already modifying their behaviors based on the expectations around that action.
Or if people know that a pandemic is imminent, they will take behaviors by themselves to modify their actions independently of lockdowns. Is that
Exactly,
right?
exactly.
Yeah. Okay.
And I think this critique is actually holding up quite a bit in some of the data that we have. So there have been studies that I know Google has this mobility data tracker that looks at just data from users of its app to see how people have moved around. Open Table, the reservation app for restaurants, released a whole bunch of data to show how restaurants have been impacted by not only the lockdown, which obviously shuts them down, but behavior before that. We're also seeing some survey data about people answering questions like, how frequently do you wash your hands? Or are you carrying hand sanitizer now when you go out into public? Or are you wearing a mask? And all of these indicators start to show around mid to late February, there are noticeable responses taking place to COVID. And it really rapidly accelerates about the first 2 weeks of March. So in the United States and in many Western European countries, this is the same time frame when they're starting to debate or starting to consider lockdowns. But all of these other indicators of behavioral responses are really leading the policy discussion, and the lockdown policies that are implemented lag behind by about 1 to 2 weeks from some of these other indicators that we have. And
So
that
are you
raises
saying that these epidemiological models frequently do not take into account behavioral responses of people?
Right, right. They assume very fixed parameters
Hmm.
based on what they assume to be the number of social interactions between people, Or they'll say that we expect a 60% compliance rate with policy X if we put it into place. Uh, that's a very flat prediction that you're kind of hard coding into the model. Well, what happens if instead of 60% compliance, it's 80% compliance? Or what happens instead of 60% compliance, it starts to scale up from 1 week to 70%, to the next week to 80%, to the next week 85%. You've automatically got behavioral changes that are unaccounted for in the models. And just quite a few of these that we've looked at. So the Imperial College is probably the most famous, and it does follow what they call the SIR or the SEIR, that refers to susceptibility, infection, and then recovery or removal. So they're trying to map out statistically the pattern of who gets the disease, who they transmit it to, what's the recovery rate. And then if we can probabilistically assume certain things about how often people are interacting in these given scenarios, we can basically calculate each of those parameters and get an output that tells us the deadliness of the disease or the infection rate of the disease. So they're very interesting models, and they're often very complex models. But I'd say generally they're not complex enough. In other words,
Mm.
they're making some very strong assumptions about things that we really don't have good evidence on, and things that are actually constantly changing in response to knowledge of the disease.
So can I ask you
Yeah.
specifically, what issues do you have with the ICL model? This is a model that has been much publicized, especially in the United Kingdom. It's
Yeah.
been used to craft and to guide policy in the United Kingdom, and it's headed by this guy, Neil Ferguson, not the Harvard
Right.
Neil
Not
Ferguson,
the
right?
historian.
No, but this guy is an Oxford physicist, I believe.
Yeah.
But Neil Ferguson's ICL model, what specific criticisms do you have uh, on his model?
Yeah. So I would say there are probably three big issues with it. And the first is consistent with everything the NBER paper pointed out. It doesn't really take into account behavioral responses. And when it does make some of these claims about the expected effect of policy interventions, such as a lockdown or social distancing guidelines, there's very little that's done as kind of like a robustness check to see if they've accurately predicted the rates that
Mm.
these policies are going to mitigate or obviate the elements of the pandemic. So that's more of a methodological issue with the way that the model's designed. The second critique I'd make of it is the way that it's been presented to governments and the public. And I think this has been more of a failing on the part of the team that wrote it, including Neil Ferguson, who's kind of emerged as the spokesman behind this model. And what you see is if you read the actual paper, it presents a whole broad range of scenarios, and they are everything from like the disaster apocalypse scenario where 2 million people die in the United States, or 500,000 was the UK equivalent of that, to much milder scenarios that are more in line with what we're seeing right now, where the deaths are in the tens of thousands. It's a very bad pandemic, but it's not something that's like spiraling out of control. And then there's a whole range of everything in between. So some of the iterations of the ICL model seem to be more closely aligned with the reality that we're seeing than others. Well, unfortunately, whenever they presented this to politicians in the press, which one gets all the headlines, which one gets the money quotes on news TV stations and in the New York Times, it's always the extreme alarmist model. And we looked from around the week of March 16th through the 20th. I think I found 4 or 5 different interviews that the ICL team, mostly Ferguson, did with the public, or advisory efforts that they made where they were meeting with Boris Johnson and other senior officials of governments. And in each and every one, the projection that they choose to highlight is the 2 million death disaster scenario, the apocalyptic one, even though their own paper says, and I quote from this, that this scenario was unlikely to play out. Yet it's the one that gets all the press. It works the public into a frenzy. The New York Times ran a piece on March 20th that quoted Ferguson directly and said that epidemiologists have projected if we don't do anything, if we don't go into full nationwide lockdown, our worst case scenario is 2 million dead. And our best case scenario, and they specifically asked Ferguson this, is what's your best case scenario? And he says, well, about 1.1 million, which is still way on the upper end of these model projections.
What
So I
about
think there's been,
replicability? Like if
I'm
I
sorry.
wanted to download that model and actually replicate Neil Ferguson's results? Could I do that
Yeah.
for Canada? Let's
So
say for Canada.
right.
Yeah.
Not perfectly, not perfectly. And there's been
Mhm.
quite a bit of a discussion around this. One of the issues is that they didn't really go through a normal means of peer review for this paper. Part of that's because they had to rush it to publication as
Sure.
the
Yeah.
pandemic's unfolding. So I can give them credit for that.
Yeah.
But the other part, it took them over a month before they fully released even like a generic iteration of their code, and we still don't have access to the code they actually ran in that model. We still don't have access to the direct data inputs that they put into there. So you can kind of ballpark it. You could probably adapt their existing code and run it for Canada. You can also, if you know the background of the underlying models, because this isn't just like a brand new thing they invented for COVID. It's an adapted model from the avian flu and swine flu pandemics in the late 2000s. This is stuff that's been published elsewhere in the academic literature. You can follow roughly the steps, which raises an interesting thing. This is probably my third criticism that I make of the ICL model, is that back in late March and early April, there was a team at the University of Uppsala in Sweden that did take the Neil Ferguson model from his earlier papers and probably some consultation to get what that code indicated, and they ran a version of it for Sweden. They ran a version basically saying, well, here's what happens if we implement a lockdown, and I think April 10th was the projected due date for the lockdown for their projection to play out. Then they also used the counterfactual. Here's what happens if Sweden keeps its current course of this lighter touch policy that we know they've implemented, and then a whole range in between. Well, that model ran. They published the results in early April, and it had a little bit of a fanfare in the Swedish press, urging the government to change course based on this model's projections. But the interesting thing we see is that now we're here a little over a month later, and the Swedish adaptation of the ICL model failed catastrophically. Put another way, that model predicted that as of April 1st, Sweden should have 40,000 deaths under its current course policy. The actual, I think as of this morning, it was about 2,700 deaths. So there are multiple, orders of magnitude off from what this model projected to do versus what is actually playing out. And that tells me that there's probably some very unsound assumptions buried into the model in the way that it's predicting behavior, the way that it's predicting the effectiveness of all of these different scenarios. So separate and apart from Sweden as a policy course that other countries could replicate on its own, Sweden's interesting because it's the one country that gives us a bit of a counterfactual. It's something that they took a very clearly different strategy than most of the rest of their neighbors in the world. So we can actually see how the
Isn't
quote
that
unquote
sorry? Isn't that a sample size of one though? Because I could also say,
is.
for example, that Taiwan has done very well, but Taiwan
Mm,
has done some very draconian things like implementing smartphone tracking technology, deporting people who have broken their quarantine.
sure,
All of
sure.
these things, by the way, I'll lay it out on the table. I think Taiwan has done a fantastic job, but it's still a sample size of one, right?
Right,
I
right.
mean, I guess
The
it's
data
like,
has shown in
yeah,
Taiwan.
yeah.
Yeah.
The data
And
has
so,
shown that Taiwan has done very well. In
yeah.
fact, yeah.
I wouldn't go so far as to say that either Sweden or Taiwan is the universal
Mhm.
model for the world.
Fair
I
enough.
do
Yeah.
think it's more useful though in testing something like the ICL model, because we can import Sweden into the conditions and parameters of the ICL model as developed in other countries and make the necessary or prescribed adjustments that you need to make that
Sure.
model fit Sweden, which is exactly what this
Mhm.
team did. And the results are not playing out in a way that's even remotely comparable to its expectations
Mhm.
from that model. So that just tells me that something is wrong about the underlying assumptions of the non-lockdown scenarios in the ICL model.
Okay, let's turn to something called the precautionary
Yeah.
principle, right? So, the precautionary principle suggests that in the presence of potentially multiplicative risks that are fat tailed in their distribution, and by that I mean things like viruses, terrorism, a plague of locusts, anything that has the potential to multiply beyond the initial event, right? So, for example, an accident, a car accident is not a multiplicative risk, because if you get into a car accident, unless there's something freakish going on, it doesn't
Right,
cause
right.
there
It
to
just
be,
stops the whole highway
yeah,
behind you.
yeah, exactly. I mean, it doesn't cause there to be a multiplicative number of car accidents. But if there's one person has a virus, then potentially 100,000 people can get it, right? As we've
Sure,
seen
sure.
with COVID-19. But anyway, let's look at the precautionary principle in the case of these multiplicative risks. In the case of such risks, the precautionary principle says it is better to overreact than to underreact. Essentially, in such cases, it is better to be safe than sorry,
Right.
or it's better to panic earlier than it is to panic later. Is this a good principle to adopt for COVID-19?
Yeah, I don't see it as something that is a universal principle here, and the reason I'd point that out is that we're not only dealing with extreme uncertainty about the virus, we're also dealing with other forms of extreme uncertainty that could invoke similar scenarios. Give you a very specific example to return to this question about herd immunity. Even though we don't know for certain how that plays out, we do have a general theory of virology that does support the concept. So, does extreme precaution in locking down society trigger other events in the wake of extreme uncertainty that prevent herd immunity from emerging? So where do, in other words, I'm asking the question is where would you exercise the precaution? Where would you exercise the point of intervention?
I'm
In
I'm
addition to
just
that,
a
I'm
little
sorry.
bit sorry. I'm just a little bit skeptical though about the idea of herd immunity in that
Sure.
case, because then the precautionary principle would say you don't want to wait until you figure out whether there is herd
Right,
immunity,
right.
right? This could be just a mild disease, or it could be something like the bubonic plague, but you don't want to
Sure,
wait
sure.
to find out that, right?
Sure. So
Yeah,
that's going to be one side of it, but the other side is going to be so
yeah.
suppose herd immunity does play out
Mhm.
and a society artificially delays it from setting in. That that they're just basically inviting a second wave that's equally unpredictable, equally risky, uh, by intentionally taking a course that deflects something that I think we have a reasonable amount of evidence to believe is at least at play in our policy decisions about it.
Okay, so there's a narrative arising that there exists a trade-off between the economy and
Right.
containing the virus, right? So this gets a little bit to this question. I was chatting with Chris Colvin about a few weeks ago, right, on this program about the 1918 Spanish flu, and he
Yeah.
pointed me to this Federal Reserve research paper,
Yeah. Yeah.
which shows that those regions of the United States which imposed a lockdown earlier and more aggressively in response to the Spanish flu experienced higher post pandemic economic growth. So, in other words, areas that reacted more
Yeah.
aggressively and earlier to lockdowns had higher growth after the pandemic was done. The idea is that locked down areas have less damage from the virus. Is this a good argument in favor of lockdowns?
Yeah. So I think the data there is very interesting, but if you look at the Federal Reserve paper in question here, it does have some very strong caveats. It points out in particular that the Spanish flu played out across the backdrop of World War One, and
Mhm.
really the end of World War One. So when all the troops are coming home, on top of that, I think they continued that study. So they did their tests by following how these cities performed economically through 1923. You had a major recession in 1920-21 that has so already you have two hugely disruptive economic events that could also be playing out in some of these effects. The authors of that study do attempt to control for them, and I think they do an admirable job, given data limitations. But what it does is it dampens some of the certainty that we can assign to the causal direction that they're pointing out here. As a historical point, this is something I'm continuing to look into on the 1918 Spanish flu responses, especially in the United States. You start to see that there are quite a few differences between what they considered a responsive policy in 1918 and what we have today. And it also comes from the circumstances of the virus. So the biggest one that comes into play is that hospitals were in fact overwhelmed in 1918. But not because hospital capacity or something had diminished or because the virus was atypical. The main reason they were overwhelmed is most of the US medical profession was overseas in Europe to treat
Right.
soldiers.
Hmm.
So they had a shortage of nurses and doctors, especially for the first few months that this thing is hitting in September and October of 1918. That was the so-called second wave of when it spreads into the United States. All of these hospitals are having a flood of patients and really no one there to treat them. That automatically is going to change the remainder of the mitigation strategies that are used to deal with the virus. If your medical system, the first line of defense against it is already under very atypical conditions. The second thing is the lockdowns that are put in place in 1918 are really executed on an ad hoc basis. It's city by city and sometimes neighboring cities. So one of the cases they often look to is Minneapolis and St. Paul that are right next to each other in Minnesota, but had two different health commissions that adopted different types of strategies.
Mm-hmm.
And the data shows that maybe school closures were more effective in one because they were more aggressive, but then there were other factors that were more effective in the other. So it gets a really ambiguous mess to tease that out. And then the other thing you get out of 1918, a typical lockdown in 1918 meant they closed movie theaters, pool halls, saloons, concert venues, large gatherings. I think they called the dividing line in 1918. It was based on whether you had a normal or abnormal amount of congestion in the venue or the area. So people coming together, that's a very different dividing line between what we have today, which is between essential and non-essential. That's often very fluid in the way that it's defined. So a lockdown in 1918 doesn't necessarily map all that well onto what we have today. So I guess to summarize all that, the caveat I'd say on the Federal Reserve study is it's very interesting. It can point to virus mitigation and treatment strategies having a clear effect of some sort on regions, and there's quite a bit of difference between the regions, but I'm hesitant to read a very hard, strong causal claim into that.
COVID-19, I think, is causing, in some respect, at least in American society, I've been observing a sea change in the way that people view experts. Experts were telling us initially masks don't work. Now we're told that masks work. They were telling us that travel bans don't work. Now travel bans are ubiquitous. And we were told various things about these projections. We talked about that. And I've talked about that on my channel as well on this podcast. You are correctly, I think, therefore critical of over-reliance on experts and the ivory tower. I'd like to sidetrack now to your book,
Yeah.
The Cracks in the Ivory Tower, which argues that university students, professors, and administrators act in a self-serving, unethical manner, hence corrupting the purpose and value of higher education. Will you just briefly summarize the thesis and how your argument of your book, and then I'll ask you a specific question about it.
Yeah. So the gist of the book is that human beings respond to incentives. And it's not out of malice that they respond to incentives. It's just understanding what are the institutional parameters that they're operating in. What this means, unfortunately, is you throw it into a system like higher ed, is you get a divergence between what people actually do relative to their careers or their job security or the degree that they want to get versus the kind of the public ideals, the lofty ideals that are put forth for higher ed. So universities are presented to the public as like these great institutions and caretakers and curators of knowledge that increase our social capital, increase our capacity to do things in life, make us better citizens, in other words. But if you ask the average student, the students say, why are you getting a degree? It's, well, I want to get a better job. So it's a very personal, more self-oriented response. And our basic argument in the book is if you identify all the individual interests of the major actors in higher ed and throw them into this institutional framework that's kind of putting forth this mythology of serving knowledge in general, you get very skewed results that are not in sync with the mission. In other words, you get a lot of people acting very selfishly under the cover of pretending to act selflessly.
So do you imagine that the pandemic will change the incentives of university professors and administrators in a meaningful way? You know, for example, we are seeing a lot of funding cuts as a result of COVID-19.
Right. So this has been fascinating to watch play out in real time. And I still don't have a full map of, I think, where it's going. I don't think any of us do because, the conditions are changing on a day-to-day basis. I will say that one of my fears is that administrators foremost, and then also faculty to some degree, are going to unfortunately respond to this by prioritizing their own self-preservation over the students that they're actually
Mhm.
serving. And I'm not saying this as someone who hates academia. I spent 10 years teaching at the college level in higher ed. I am very much a creature and product of higher ed, but we often see that student interests, even under normal conditions, were taking a backseat to administrator growth and bloat of budgets spent on superfluous things on campus. They were taking a backseat to the way that curriculum was designed. In other words, some departments are probably much larger than they need to be. Other departments are much smaller than they need to be, but they've been able to successfully rent seek on campus for resources in ways that don't align with what the students want. So that was already taking place. What I fear is that we're going to see more and more of that now that this crisis has thrown higher ed into potentially very severe and dire budgetary straits. So the question that emerges there is, how do they respond? Well, unfortunately, the early evidence we've seen is not too well. You already have students that are asking questions like, hey, can I get a refund for my dorm for the rest of the semester that you kicked me out of? I paid for
Yeah.
4 months and only got to stay there for one. And universities are saying, well, yeah, we can kind of do that, but they're also kind of gaming the dates. So like there was an example I read about yesterday. The campus closed on like March 3rd or something, but they were only refunding after March 28th, because March 28th aligned with the date the city that campus was in went into lockdown. So even though the campus predates the lockdown and really kind of screwed students out of basically a month of their dorm payments, they were gaming it to say, well, we're gonna prorate your fees this semester, but we're only going to do it after this lockdown was official, not the date that we imposed it. So that screams to me that there are some very bad actors in higher ed that are trying to game around the margins in ways that are probably not in the interests of students. Where does this go out from here? A lot of it's going to depend on what we're looking like in the mid to late summer, and the question about do we reopen in the fall and how so comes into play. If we stay on the current course, and I'm not assuming we will, but say that there are still widespread closures in the fall, that's where you start to get to the point where students ask the question, is this $50,000 fee I'm paying to attend an elite university worth it if I'm just sitting at home and taking classes
Mhm.
online?
All right, so we're getting towards the end, but I'd like to ask you, Phil, where can we find you? Do you have a Twitter? Do you have a website? I know you do, but
Yes,
plug.
absolutely.
Oh, do you?
So I
Yeah.
do most of my shorter articles and commentary on American Institute for Economic Research, and that is AIER.org. We run a full suite of analysis on current events and historical events. I also have a personal blog at philmagness.com. That's where I put up a lot of my working papers and shorter commentaries. And then Phil W. Magness is my Twitter handle. Feel free to follow, like, join into any conversation that we have there. And
It's a great Twitter, by the way. I do follow you quite a lot.
thank
You're in some very interesting debates with economists, and I find it fascinating. You criticized recently the 1619 project.
right.
And, I mean that's an entirely separate interview, but
Yeah.
I've really enjoyed your Twitter, and AEIR, pretty great. Vincent Galesso, who was on this program,
Yep.
also writes for AEIR. So I would like to thank you very much for joining us, Phil. That was a very fun interview. Thank you.
Absolutely. Absolutely.
And
Anytime.